I want to thank everyone for coming out virtually out this evening to have this really amazing conversation with us tonight. We will be talking about health equity through research and pretty much a discussion with frontline physicians throughout the pandemic. And we have an amazing panel this evening. We felt, my name, by the way, is Elena Stinson. I'm an emergency medicine physician, also the president of the New England Medical Association. And those who are not familiar, we are an affiliate of the National Medical Association, newly founded over a year ago, really bringing a robust community of Black physicians, residents, and students to the area, and really wanting to reach out and build safe spaces, opportunities for networking, be able to advocate for our communities that we serve, and also to do work within the community as well. As it pertains to NEMA, we have partnered with All of Us Research, and we have worked quite a bit over the past year together. You may have seen some of their information in our newsletters, but we are most excited about this event that we're bringing to you guys this evening. As you know, the pandemic was extremely, it was crazy, the craziest thing we've probably ever seen in our lifetime, and hopefully probably the craziest thing we will ever see. But it really highlighted a lot of things that we did well in the healthcare system and a lot of things that don't really work so well. And it left a lot of patients in various communities vulnerable. And one thing that we saw is that we really wanted to have more conversation around how we're thinking about race and equity in the space of science and research. And specifically how we're thinking about how the funding is getting to the community, how the research is being tailored to various communities, and how we're bringing more diversity into the space of research scientists and conducting these research projects, so that we're ensuring that from everything from medications to how we're managing and diagnosing patients are addressed in an equitable manner to where we're closing those gaps in health equity or health disparities, my apologies. As you know, a lot of times when we talk about health equity, we usually will talk about it in the sense of social determinants of health, but we want to take away tonight that it's much more than that. And there's a lot of different pieces that go into us solving these issues of health disparities. So we want to kind of kick it off with just Dr. Vonzella Bryant, who's going to give us an overview of how these social determinants of health impact our health, and historical reasons why these disparities exist to this day. So Dr. Bryant is the VP of Operations with New England Medical Association. She's also a board certified emergency medicine physician at Boston Medical Center. She's the emergency medicine clerkship director and assistant professor and assistant dean of student affairs at Boston University School of Medicine. Because of her work on the front lines of the coronavirus pandemic, she earned a spot in the US News and World Report list of hospital heroes with Dr. Fauci and Dr. Gupta. That's a big deal. And was selected to be the Celtics hero among us. So I would like to have Dr. Bryant go ahead and talk to us a little bit more about why this is important and why we need to focus on social determinants of health.
Thank you, Dr. Stinson, for introducing me. And I'm so happy and excited to be here as well, as far as this collaboration of all these great researchers and physicians. So a colleague said, sometimes it takes drama to see something that has been in front of our faces the whole time. And this pandemic has definitely highlighted all the health disparities that we have seen among the Black and Brown communities. It has shown that we've had severe to deadly COVID-19 illnesses among our communities. But why? And when we think about it, we have to think about the hundreds and hundreds and hundreds of years of systemic racism that is embedded in our country's fabric. We've had lifetimes of legal segregation, or well, going back to owning a home. We have now know leads or is a link to having generational wealth. But unfortunately, because of lifetimes of legal segregation and also decades of racist housing policies like redlining, where certain areas were deemed to be a poor financial risk. And unfortunately, those were the areas where Brown and Black people were able to live. So with these economically depressed areas, You had under-resourced schools, which decreased the chances of your kid to be able to go to college or get that better paying job. Also, they tended to be in areas that were crowded and had multi-generational homes. And with that, it's hard to do social distancing during COVID. Also, these areas tended to be in around pollutants that were in the air or in the water due to having factories that increase your risk for having cancer and also increase your risk of complications with lung problems like asthma, which those are big factors for having severe COVID illnesses. Also, I just want to put a pause. These areas also had high unemployment rates, which tend to lead to higher violence. And so that caused folks to smoke cigarettes or increase cigarette smoking in these areas. Also, they were located in food deserts where there was a paucity of healthy food choices, which increase your risk for obesity and also increase your risk for complications of your diabetes, of which, again, COVID, those were the things that COVID snapped on. And also there was lack of adequate transportation, again, to get that better job, but then also to have access to certain healthcare systems. It's all these things that are related to the social determinants of health that lead to poor healthcare outcomes. Also, only 20% of Black Americans were able to work from home during this pandemic. And we had the largest share of frontline healthcare or frontline worker jobs, such as, those Amazon delivery folks or being a nurse assistant in the hospitals or environmental workers. It was that exposure to the virus and also those comorbidities that led to having severe to deadly COVID-19 illnesses. So when I say Black Lives Matter, I mean, I know there's a lot of things there as far as Black Lives Matter, but I feel like it means that we need to invest in Black lives as far as those social determinants of health that lead to poor healthcare outcomes. And as far as the distrust among the brown and Black communities, that's real, it's justified. I mean, when we look at the historical context as far as medical experimentation, like the founder of OB/GYN, he developed tools and procedures and experimented on slaves without anesthesia. Also even to Tuskegee, where these Black men thought that they were getting free healthcare, but it turned out that there was they had syphilis that wasn't being treated, which could be passed on to their partners and also to their newly born children, causing all kinds of health problems. Also, we have this thing that we are learning about race-based medicine, where we used to use race as a shortcut, like saying 38-year-old Black male, history of tobacco, but we kind of use race as like, oh, well, they're totally going to have heart problems or they're going to have this kind of high blood pressure where they should be on this certain medication. And with all of that, that led us to having misdiagnosis and also mistreatment of our patients. Also, as far as the distrust, the way that patients feel when they come into our clinical settings, if a patient doesn't feel valued or respected, well, how are they going to trust our medical recommendations? And also have to put in a plug as far as diversity matters, because when patients see a more diverse workforce, they'll be more trusting and there'll be decreased bias among healthcare workers. It is all of that where we need to have more studies and research and data collected so that we can create the equity that we need. And I am so happy to be with all of us as far as the work that they do. I'm going to pass the mic.
And I want to thank Dr. Bryant. She pretty much broke down to us how all these social determinants impact one's health. Basically, where we live, how we live, what we eat, how we come and go, all play a big factor into like our health outcomes in some form or fashion. But in addition to that, the research that we do in combating some of this is also very important. So I would like to bring up Dr. Cheryl Clark, who is going to give us an introduction to pretty much All of Us research and just how using research can benefit the communities that we care for. A little bit about Dr. Clark. She is a principal investigator for All of Us New England, and she leads the New England Consortium of bi-directional community engagement efforts. Dr. Clark co-leads the Social Determinants of Health Task Force and Measuring Social Determinants in All of Us. She is hospitalist physician at Brigham and Women's Hospital, where she led the hospital equity response to COVID during the early phases of the pandemic. Hats off to you, Dr. Clark. Her research focuses on contributors and strategies to eliminate inequities in cardiometabolic risk and care utilization for cancer and cardiovascular disease prevention.
Thank you so much, Dr. Stinson and Dr. Bryant, for hosting us and having us here tonight. And really want to thank my co-panelists in the audience for attending tonight. And I wanted to start by building on the context that Dr. Bryant gave to us tonight with a quote from the Harlem Renaissance, a poet named Zora Neale Hurston, who talked about research. And she said it's really just curiosity with an agenda. And as we think about research and how we ask questions, that's how we are going to move this forward. Just having that empathy, having that curiosity, asking, what is it that we can do differently? What is it that we can change? What can we do better for our personal health, for our communities, for our environment? That is really the underpinning of all of us. And so wanted to thank everybody for giving that background. And I wanted to start with that idea. I'd like to go to the next slide. One really important change, I think that's happened recently, is that the unconscionable deaths and murders that we saw of African American men and women, people of color, over the past year in such a public forum, really, I think, brought this to our consciousness, that the drama, that Dr. Bryant spoke of, made it somewhat easier, I would say, for us to start to talk about it and to name issues like structural racism as a part of trying to understand healthcare and broader social determinants. And I cannot tell you how much it meant to me as an African American researcher to hear the CEO of the All of Us research program present this slide. The National Institutes of Health is the largest government agency that funds the health research that really impacts all of our lives. And the National Institutes of Health has put out this call, and the director, Francis Collins, to do more research so that we can be curious and start to ask questions about why do we have high blood pressure that is different by these social categories like race? What is it that we need to be doing differently? And so the All of Us research program, which I'll describe to you in the next slide, really does embrace this idea and tries to move this work forward. So I'll get to it in the next slide. The All of Us research program is the largest funded research program for the National Institutes of Health. It was launched by a congressional appropriation, actually during the Obama administration, and began to recruit participants in 2018. And the mission of All of Us is really all about people. It's the idea that we need to be curious and we need to ask questions to accelerate breakthroughs and to try to think about how can we make sure that when we develop new treatments, that they really do fit and they really are specific to people and to communities that need those treatments and prevention efforts. It's the goal of the All of Us research program is to accelerate something called precision health or precision medicine. The idea that we really need to tailor our medications, our public health approaches, and our health approaches to the needs of communities, the needs of individuals. And the goal is to bring in 1 million people across the entire United States to do this. We are trying to nurture relationships. So making sure that we stay in touch and that we provide bi-directional benefit. And we can talk about what that means to participants over a 10-year period. So we're asking people to join the study and to participate for 10 years. We want to make sure that we don't make mistakes that have happened in research in the past where we exclude people. And so the goal here is to deliver and to have the largest, most rich, most diverse group of people to contribute their information so that no one is left behind. We want to make sure that we also embrace a community of people who want to do research. And that's one of the reasons that we're here today. The information is not going to just pop itself. We need to have people who are asking the important questions and looking at the information and helping to move this forward. And in doing that, we will maintain a very strong team because it really does take everybody to achieve this mission. Let's go to the next slide. One of the questions is who is participating in the research program? And one of the exciting parts of this is that the program really has achieved great diversity by race, ethnicity, sexual orientation, gender identity, disability, income, education. It's really geography, like different states, you can sort of see that. I happen to put slides here that show you a little bit about both the age and racial and ethnic diversity here, just to give you a flavor that the program is really reaching out all across the country and has engaged several communities and has worked very closely with community-based organizations to do this work. Let's go to the next slide. And so if you do all of this work, let's see, I think we might be able to get the next slide up. If we do all of this work, one of the questions is, what do we do with the data? And I'll show you a slide in a second that shows you that the data in all of us are really rich. As of today, toward our goal of involving 1 million people across the United States, we are now at 394,000 plus people who've agreed to participate and who have given their information. And someone before as we were preparing for this webinar asked us, what kind of data, like what sort of information is available in the program. And right now we have information from electronic medical records. People donate their records so that we can understand what their health conditions are like. They answer questions from surveys so that it's not just about your genetics, but we do ask those questions about your biology, but also we will be asking people about where they live, where they work, what their relationships are like, and where they worship, if that's a part of their lives. And also physical measurements. And so if you're interested in high blood pressure or weight or these sorts of things, you can do that. We have also coming soon, blood specimens. So we draw blood and get saliva so that we can look at health, biology, and also mobile technology. You've heard of Fitbits and things like that, so that we can get a better sense of what people are doing. And I put the website below, databrowser.researchallofus.org. You can just play with it. And if we have some time, we might even be able to pull it up and just sort of look at it. But one powerful part of this is because it is funded by the United States, it is open for everybody. So you could go to the website right now, go to the data browser, play with it, and that information will not reveal anybody's personal data, but you can look at the big picture and you can start to even play with it right now if you want to give that a try. Let's go to the next slide. So if you have all this information, what can you do? I wanted to talk a little bit about the project. So one project that has been funded and we're currently looking for participants or I should say centers to do this work is nutrition. Like, what is it that we ought to be eating and who should be eating what to promote health, and knowing that in a very deep way. Let's go to the next slide. What else can you do? an important part of our work, and we're speaking from the New England Consortium, is to make sure that we work very closely with our local communities to understand what the needs are and to make sure that the people who participate in the program get the benefit. And I am the PI of engagement for New England, which is both Mass General Brigham, Massachusetts General Hospital, Brigham and Women's Hospital, Faulkner, and the other hospitals that you see listed, as well as Boston Medical Center, which is the largest safety net hospital in Massachusetts and in New England, actually. Let's go to the next slide. One of the important pieces, and if you remember nothing else, that really ties into what Dr. Bryant shared with us today, is that if we hope for health to get better, research and care has to be trustworthy. We have to be transparent. We have to partner with each other in ways that that create benefit for each other. And we have to make sure that the way that we do research is trustworthy, so that people participate and that we learn from each other and we learn together. And that is our philosophy, and we try to put that forward in everything we do. Let's go to the next slide. What I will show you next is how we do that. The pandemic was devastating, and it's hard to remember this, but at the beginning, most of us had no idea what was going on. You know, when it really happened in March 2020, what is coronavirus? um, the entire economy shut down. How do I get food? People were isolated and lonely. And our team in New England at that time had 20,000 people who were our participants. And we used research to care about people. And our research assistants called all 20,000 of our participants to ask them if they needed anything, are they doing okay, and to offer resources around mental health, housing problems, food problems, and how to get those solved, and food delivery services at the time. And if we go to the next slide, what you'll see is that this is also an equity issue, that we added value by caring about the people who participated in our research study. And particularly, this happened for our community health centers. Many people in Chelsea Community Health Center, those of you who are local know it, Revere, Brookside, Southern Jamaica Plain, all said that they valued and wanted those resources and were very engaged in that kind of work. And so as we think about what it means to change, you know, what it is that we have to do differently, what it is that we want to do together, we want to be curious. We want to ask those questions. We want to make sure that we care about each other. And if we can click the next slide, you can read about our approach. It just got published in a journal, Ethnicity and Disease. So we're also pushing the field forward so that others can follow our approach. So just the last couple things I wanted to mention on the next slide is that this is not going to happen without you. We need your ideas. We need your partnership. And we want to work in collaboration. And so this is the first conversation of what we hope will be many for the folks who participate on this call. And you are going to hear very talented physician researchers who are moving this forward and are inspiring us on what to do next. And on the last slide, I want to thank Elizabeth Antonellis, Meg Bohr, and Cheryl McLeod, who are the engagement team. They are the people who are making this happen on the ground and keeping us engaged. And so with that, I appreciate it and thank you for listening.
Awesome. Thank you so much, Dr. Clark, for really giving us that background information around what all of us is doing and the approach that you guys are taking to really delve in and be able to ask those questions and be curious. That something that you mentioned from the poem by Zora Neale Hurston, and being able to provide treatment and prevention efforts in a more targeted manner that will address the needs of communities in a more specific way. And I think, you know, what we heard from you is that this work is being done, but there's still a lot of work that needs to be done. And more specifically, what came up in my mind after going over all of that is like, who's asking the questions, right? And how diverse is that group that's asking the questions, and how important is that in ensuring that you're how important is that to make sure that you're asking the right questions to address the needs of communities? So my question to you is, how can we improve the diversity of people who are actually doing the research? Because it's important, right, to have that diverse opinion of thought at the table.
I think that's exactly right. And I don't see another way of doing it than doing the outreach, making sure we get the word out so that people know that this is available, but also that we do the investment. So all of us is at the beginning of that journey, but on the path to making sure that additional resources are being put forward to support institutions that where we have a diverse group of people, historically Black colleges and universities and other institutions, to make sure that the word gets out and that people have the resources they need. And certainly if you are local, if you're in New England and want to partner with us to do this work, we want to make sure that we make that happen. And so a lot of it is just what we're doing today, the transparency, the partnership, all that's necessary.
Awesome, thank you. And I do want to remind people, if they have questions, feel free to drop it in the chat and we'll get to those along throughout the evening. And then if we don't get to them during our conversations, we will have a Q&A at the end. So that's really important, that collaboration, building that trust, bringing in the right partners to make sure that we're doing the work in an effective manner. But you mentioned also around precision medicine and health, because this is important, because there's a lot of chronic diseases that we are dealing with in certain communities of color. And it's important that we're doing this research in a manner that we can provide the right treatments and recommendations to these communities that we're not moving the needle in. So I wanted to bring Dr. Paulette Chandler to the stage and have her talk more about hypertension research that she's doing, and just give us some examples of where research is going, and kind of talk a little bit more about precision medicine if possible. A little bit about Dr. Paulette Chandler. She's also a co-investigator for All of Us Research. Dr. Chandler is an assistant professor of medicine at Harvard Medical School, associate epidemiology in a division of prevention medicine, and a primary care physician at Brigham and Women's Hospital. She served as lead for community engagement and education for COVID-19 vaccine trials at Brigham and Women's Hospital, and is currently serving as associate medical director, clinical science in the GI therapeutic area unit at Takeda Pharmaceuticals. So thank you, Dr. Chandler, for speaking with us this evening.
Great. Thank you so much. Glad to be here. I'm just going to share my screen. So I'm driving the slides here. As Dr. Clark mentioned, All of Us is an amazing program with such a diverse data that's been from the participants that have agreed to share their electronic health record data as well as their survey data. So what I'm going to talk about is one project that we completed looking at hypertension or high blood pressure in this cohort. There were many different projects that were done just to test the database to see how well the data was, brought into the data set, as well as the tools, the workbench, the All of Us Research workbench, which allows researchers to use the data. So in this project, we wanted to see, could we mirror the high blood pressure measurements that have been reported in other cohorts and in published data? And for our hypertension definition, we decided to use the electronic health record. And we looked at the diagnostic codes for essential hypertension, meaning not secondary hypertension. And we used the medications that were recorded in the electronic health record. And we already had some evidence of an algorithm that could work to define hypertension in the electronic health record based on the eMERGE cohort, which is the electronic medical records and genomics. And they developed an algorithm for identifying individuals with hypertension that did not include race. So often, we include race when we're thinking about, oh, is this person at risk for having high blood pressure? Well, this algorithm did not include race. It was just based on the code, the essential code, SNOMED, which is the systemized nomenclature medicine code. That's how you harmonize data when you think about bringing in all these different electronic health records to look at data. And then they had to have a code for hypertension on at least 2 distinct dates and at least one medication from the various hypertension medication classes. And the beauty of defining a definition like this, it can be transferred into other, data systems that can be used clinically to identify people at risk for high blood pressure. Then you can think, oh, I could roll out a lifestyle intervention for these people. I could roll out a list of resources for these communities, these individuals that have been identified through the electronic health record as having hypertension. So you can imagine this would be a great way to improve management of hypertension as well as prevention of hypertension. So what we found in the All of Us study was that we were able to demonstrate similar patterns of hypertension in all of us compared to the NHANES, which is a national cohort where they sample about 5,000 people nationwide. They get detailed survey information, physical measurements, as well as blood markers. And we saw similar distribution according to age and also by gender, meaning that men are more likely to have high blood pressure. And as you get older, you're more likely to develop high blood pressure. And we published our findings in scientific reports this past month. We also looked at it by race, and of course, it's self-defined race, but the beauty of All of Us, we'll also have genomics, so we'll be able to look at it by, ancestry, genetic ancestry. And as we've noted in previous studies, Blacks have the highest prevalence of hypertension, over 35%, compared to, Asians with 20% prevalence, and Hispanics with about 22% prevalence. And the beauty of All of Us, since it is a nationwide cohort, we could look at it by region, and we were able to again see that East, South, Central region had the highest prevalence of hypertension. Of course, we know that's the South, and we know that as the stroke belt. And the reason we care about hypertension is because it increases the likelihood of someone having other bad outcomes like heart attacks and strokes. And of course, the South is known as the stroke belt. So we were able to replicate those findings. So this is great data in the sense that it will be good to look at how, diet, exercise influences high blood pressure, but also how other things like economic status. Similarly, in this cohort, we found that those that were poorer, had lower income, lower educational status, had more hypertension. They had a higher prevalence of hypertension. And these findings are very supportive of the one, that algorithm works. 2, the data is rich. And 3, we can think about lifestyle interventions. And of course, we have the precision nutrition studies that will be rolling out, and we're hoping that our participants will enroll in those studies. We have Boston Medical Center, their cooking kitchen that's going to be offering cooking classes to our All of Us participants, but also to the community. And we have many other resources in Boston that we are partnering with that will be able to offer cooking classes as well as information about access to healthy foods. So when you think about hypertension, you often think about, okay, we know it's driven by lifestyle, but also the structural factors, the economics. You lose sleep, you have higher cortisol levels, you get a surge in the blood pressure, you're working 2 or 3 jobs. So that's the economic factor, living in crowded areas, having a stressful environment, having gunshots or other things that drive up your stress will drive up the blood pressure. So this, All of Us, will allow us not to just look at the nutrition and the exercise, but also the social determinants of health, the other social determinants of health that influence blood pressure.
Wow, thank you, Dr. Chandler. Really gave us more of an insight on like how social determinants are impacting our health, in particular around hypertension, and what's being done at All of Us to kind of really be more precise around how we're addressing hypertension within patients through nutrition. And then you brought up genomics, and then economics and a lot of the social determinants of health. So amazing how we're able to just really take all of this, and you're able to use electronic medical records and just really target your treatments to your patients, which I think is extremely helpful. But I think, as we talk about this, clinician scientists are able to do this work in their offices and their hospitals, but what mechanism can the average citizen utilize to increase health equity in their communities around some of these topics that you mentioned?
Right. I think some basic strategies that we can do to improve health equity is one, thinking about improving access to healthy foods. And you can volunteer with organizations that are doing it. For example, Sportsman Tennis Enrichment Center, Vital Connections, they're partnering with organizations to get the community, make the community aware of where food is being offered for free. Because I saw a post in there saying that, can you have it fast and healthy? Well, guess what? In Boston, we have amazing resources that help connect people with food that is actually free. And if you can't get to the spot, they will deliver it to you. So that's one way of improving health equity. And then thinking about how being part of these advocacy organizations, you can't be involved in everything, but you can decide, okay, I'm going to champion access to healthy foods. And Sportsman Tennis Enrichment Center is one place where if you want to be a part of that advocacy work, you can work with them. They're also offering free exercise classes. And there are other programs that are working on helping people get access to housing, buy their own homes. Some of my colleagues that I work with, they join this Zoom platform every Tuesday, and they're learning out how to navigate the system to get qualified for a home loan and actually, get bills in place so that they qualify and be able to buy their own home. So there are lots of different ways to think about how do you improve equity, but each person has to decide what their interest is and then join the fight. And I see some, there are all sorts of organizations, church organizations, community organizations, even your hospital patient advisory board is another way to do it.
Yeah, absolutely. Thank you for that input. And I think that's important to think about these social determinants of health and how they're addressing our efforts in reducing, like you mentioned, home loans and finding safe housing and being in areas and environments that just minimize stress, and just by in and of itself is reducing our cortisol levels. So that's so many different things that we can do in the community, even if we're not physicians or physician scientists. There's so many things that we can do to engage our communities. So thank you very much, Dr. Chandler. And you mentioned genomics. So I wanted to just jump a little bit more into that a little bit. I wanted to introduce Dr. Julian Dedier, and I think I said it right finally. And really want to jump into why it's important for diverse communities of color to participate in research, and especially when it comes to genomics, just kind of giving us a little bit more in depth of like what genomics is and why this is important. But just a little bit more about Dr. Dedier. He is a co-investigator also of All of Us co-investigator for All of Us Research New England. And after receiving his MPH from the Harvard School of Public Health, he has served as a primary care provider at Boston Medical Center for over 20 years. His research interests have included understanding the influence of ethnic, cultural, and environmental factors on risk-related behaviors for cardiovascular disease and cancer among underprivileged urban minority groups. As a co-investigator for All of Us research program, he is committed to building a research resource that reflects the rich diversity of the US population. So thank you, Dr. Dedier.
I am just enjoying this panel discussion, I must say, and thank you very much for inviting me to be on it. And thank you to all of you who've attended. So I know that this is a mixed audience. Some of you are physicians, some of you are other health providers, but some of you are most likely lay people. So that we're all on the same page, I'd like to briefly define genomics, because that's the new, exciting, cutting edge technology that I'm going to be talking a little bit about. Genomics is the study of a person's entire genome, including interactions of those genes with each other and with the individual's environment. And that's what I'm going to be talking a little bit about today. So I'd like to show the first slide. I'll wait for that to appear. So for the physicians or providers among you, this is an example of a potentially life-threatening disorder that's up to 5 times more common in folks of African descent. Would anyone like to hazard a guess in the chat what this disorder is? Give you just 2 seconds. We weren't expecting a quiz. Okay, let's click to the next slide, please. This is a picture of angioedema. So we heard the term racialized medicine. Let's keep that in mind as we go through these important points. Sometimes we do equate race with disease risk. And I think it's important to say from the outset that race is a social construct, and current racial groupings like those that the census uses are very broad, not scientifically based, and they were never purported to reflect meaningful genetic categories. We know that 99% of the human genome is shared by all people, which means just 0.1% of the genome accounts for all of the variation between people. It's helpful, I think, to think about that 0.1% of genetic variation as what has allowed people groups to adapt to their unique environments throughout history. The idea is that people groups migrated into different geographic environments, and the unique selection pressures that they encountered there favor genes that conferred a survival advantage in that environment. So, for instance, sickle cell trait, as many of you may know, makes red blood cells more resistant to malaria. And this trait is more prevalent in the Fulani people who live in parts of Africa where malaria is endemic. Another example is the APOL1 variant in West African ancestry groups that confers resistance to endemic Trypanosoma brucei infection, which causes something called African sleeping sickness. Interestingly, studies have not found that specific variant in people of Japanese, Chinese, or European ancestry. So scientists refer to the people groups who share selection pressures and their progeny as ancestry groups. And it turns out that it's actually scientifically plausible to say members of the same ancestry group may possess gene variants that differ from those found in other ancestry groups due to these varying selection pressures. But it is not valid to use race as a proxy for ancestry group in genomic studies for at least 2 reasons. So number one, there's been a lot of intermarriage between ancestry groups over time, which would cause mixing of the gene pool. And number two, and this is important, even where ancestry groups are still relatively well preserved, there are many ancestry groups within a given so-called race. So in other words, to capture the full spectrum of genetic variation, it's important to include many ancestry groups in genomic research. The problem is that people of European descent are overrepresented, certainly historically overrepresented, in genomic data sets available for research. So let's go to the next slide, please, which shows this phenomenon very well. Thank you. So this figure shows the racial breakdown of participants in genome-wide association studies from 2006 through 2018. So first, a word about genome-wide association studies. It's a method to identify what genes might be associated with a particular disease. And the basic approach is to sequence the entire genome of a bunch of people with a given disease, let's say hypertrophic cardiomyopathy, for example. And then you compare these genomes with those of an ancestry-matched group of controls who don't have the disease, and look for consistent differences between the genomes of both groups. And differences that are found may relate to the disease in question. So in this figure, the y-axis shows the number of participants in millions, and the x-axis is years. The bar on the far right here shows the proportion of the different geographic and racial groups in the world as a whole. And what we can see up in red here, both in this part of the figure and also in this bar, is people of European descent. So these are white people, essentially, accounting for maybe 1/6 of the world's population. Next in light blue here, we have East Asians. In the darker blue, Southern Asians. Africans are here. Hispanic, Latinx ethnicity groups are here. At the very bottom, you have Middle Eastern However, going back to the actual figure to its left, what you'll see is, starting in 2003, just for reference, the first human genome was sequenced. As of 2009, about 96% of participants in genome-wide association studies were of European descent. And by 2018, this number had declined to 84%, primarily because of increased inclusion of Asian populations. Happily, since 2018, the number of genome-wide association studies involving African Americans, Amerindians, people of Hispanic or Latino ethnicity have increased because of large-scale genomic studies like the TopMed program, the Human Health and Heredity Initiative in Africa, and now, happy to say, the All of Us research program. But it's important to know that there are real-life clinical implications for working from non-diverse genomic data sets. First, gene variants that appear to be pathogenic in one ancestry group may not actually cause disease in members of another ancestry group. So for example, certain genes of the LPA variety did cause cardiovascular disease in certain groups, but had actually opposing effects in other groups. In another example, African Americans were more likely than whites to be misclassified as having pathogenic gene variants for hypertrophic cardiomyopathy, when in fact, the variants were actually benign in these African American patients. And the authors of this important study that was published in the New England Journal of Medicine showed that this misclassification occurred because there were just too few African American people in the control groups of the studies that initially correlated these genes with the disease. So that just shows that it's important to test genomic associations found in one ancestry group in other ancestry groups to see if the associations hold. And here's another example. When people of African, Asian, Native American, Pacific Islander ancestry get a DNA test, the result may come back saying, this is a gene variant of uncertain significance. So of course, doctors and patients don't know what to do with that information. But interestingly, that designation of uncertain significance is less likely to occur in folks of European descent, simply because there's more reference data for Europeans than for these other groups. So it's important that a variety of ancestry groups serve as controls for potentially significant genes identified in any other ancestry group. So another reason why it's important to get diverse representation in genomic studies is it's impossible to identify a pathogenic gene if it doesn't even exist in the population that you're looking at, like the APOL1 gene I mentioned earlier, found in people of West African ancestry, but not found in Japanese, Chinese, or European ancestry groups. So it's important to maximize the gene pool under study by including many different ancestry groups in genomic research. In fact, not doing that while pursuing precision medicine may actually worsen disparities unless efforts are made to ensure diversity in genome-wide association studies and in large genomic studies in general. So you may be asking yourself, why is it important to include diverse populations in genomics research when we already know that non-genetic factors like economics, health-related behaviors, education, the built environment are such strong drivers of health and health disparities across the lifespan? Isn't this racialized medicine that we're promoting when we talk about genomics and health? So I would argue that it's important to understand how genes might interact with non-genetic factors to influence health and disease. For instance, it's likely that socioeconomic stressors contribute to disease by turning certain genes on or off. And ironically, studying the relative contributions of genetic and non-genetic factors can also help dispel myths about how much genetics account for different health outcomes between people. So the All of Us research program is collecting information on a wide range of variables, as you heard, genetic and non-genetic, that can affect health, and will make it possible for these important studies to occur. So All of Us is doing a lot to facilitate genomics research in diverse populations. It plans, as you heard, to produce genotypes and whole genome sequences on 1 million or more core participants. Let's have the next slide here, please. Thank you. So this figure shows essentially what the genetics program that All of Us is doing contains. All of Us is currently returning results on so-called recreational genetics, pictured at the top of this slide, and on health-related genetics, pictured at the bottom of this slide. So what are recreational genetics? Specifically, that consists of genetic ancestry information, and also something called genetic traits, which are kind of superficial traits, like can you taste cilantro? Do you get flushed when you drink alcohol? Do you like asparagus? So the health-related genetic information is 59 genes, essentially, that have been certified by the American College of Medical Genetics as medically actionable. So what that means is you get the result of this genetic test, and there's actually something that you, your doctor, can do about it. All of Us is also returning results on 7 genes involved in how the body processes medications. There's also, in this, if I can point out, the genetic counseling resource, which is located on the slide right here. So basically, this is a team of trained genetic counselors at All of Us who disclose all positive test results on health-related tests to the participant by phone. The counselors provide interpretation and counseling to that patient at the time of disclosure. And in addition, the All of Us research program offers confirmation with a clinical genetic test of the research test that they report to participants, so that the information is now clinically actionable. We can also explain positive test results to the patient's PCP and can actually refer the participant to local specialists based on the result. The genetics counseling resources team can also share results of the patient's genetic test with family members and explain the implications of that test for family members. Maybe we'll show the final slide here, please. So I hope you'll consider joining the All of Us research program and consider encouraging your friends and your family and your patients to also. Thank you so much for your attention.
Wow, thank you, Dr. Dedir. This was really amazing, just hearing how, high-level social determinants of health, how that kind of trickles down and all the way to the genetic piece of it, how that plays a factor in how we process our medications, and how we are diagnosed and things like that. And I think the most important piece of this, and the most important thing that came out of this conversation, is how we use race as a factor as to how we classify our patients and determine what we're going to address or what they're at risk for, but we don't really know until we've dug a little bit deeper and done some of these genetic studies. And I think one thing that you talked about is like associating a specific race with a disease. As you mentioned one ancestral group may not, that disease, that gene may not show in one ancestral group and cause that disease, and it'll show in another group. So it's really important that we really think about how we're thinking about our research, and wanting to think about getting involved with the genetic side of it. And more importantly, anyone who has questions or concerns, there are call centers and groups to call and counselors to talk to about some of this. But really understanding, because as you mentioned, just racializing medicine, like this is not what this is. And I wanted you to just really answer, what does it mean to be anti-racist in genomic research? Because what we don't want to happen is really try to drive the whole precision medicine piece and just really widen disparities if we do not do this right.
Yeah, that's a great question. So in my opinion, being anti-racist in genomics research means 2 things. I think first of all, it means not assuming the genetic differences between people necessarily explain differences in health status or academic attainment or any other measurable factor, but rather that we're all human beings and are fundamentally equal on that basis. So I think that's message number one. At the same time, I think being anti-racist in genetics research means acknowledging that different selection pressures experienced by different people groups over time may have given rise to genetic variance in one ancestry group versus another, and that the effect of a gene in one group may not be the same as the gene variant in another group. So for me, being anti-racist in genetics or genomics research is balancing those two concepts, that we're essentially the same. Everybody shares 99% of the same genetic information. But in the instances where there may be differences, the differences may not apply by definition to each ancestry group. And I think also thinking a little bit more finely about race, that it's really the ancestry group, it's the selection pressures that are specific and historic that may drive these differences where they exist, and it's not a matter of one race, so-called, versus another.
As we kind of move along, really wanted to think about how all of us is really thinking about bringing in participants into the research and the retention piece. So I wanted to bring Dr. Naya Noel to the stage and have her kind of talk a little bit more about what this looks like and some of her survey samples that she's been working on with her participants. And Dr. Naya Noel is a co-investigator, I cannot say that word today, a co-investigator of All of Us New England. She is also the Vice President of Partnership and Outreach for the New England Medical Association. Dr. Noel is Director of Minimally Invasive Gynecologic Surgery in the Department of Obstetric and Gynecology at Boston Medical Center. She is also an Assistant Professor at Boston University School of Medicine. Dr. Noel is a recent recipient of a Forward for Health Equity grant from Myovent Sciences, which she will use to found a fibroid center at Boston Medical Center. She is also a co-investigator of the Prenatal Aspirin Project, an initiative to increase the use of low-dose aspirin in pregnancy to reduce the risk of preeclampsia and preterm birth. So thank you, Dr. Noel, for speaking with us this evening as well.
Thank you, Dr. Stinson, for that introduction. And I'm really enjoying this as well. I share similar enthusiasm as the rest of my panelists to see all of you here this evening. And one thing I wanted to comment on about the chat is that it's really wonderful how people are generating specific issues that they see in their community. These are things that we hope will be studied using the All of Us data set in the future. And so here, I'm just trying to represent the fact that I had the opportunity, as my colleagues, Dr. Clark and Dr. Chandler did, to conduct some demonstration projects and using the All of Us cohort. And we aim to explore the data, the variables, and what can be studied. And it is true that All of Us cohort is a growing source of diverse longitudinal data, meaning it's going to be different data points over time as our participants continue to complete the surveys. And it can be utilized to study things that I'm passionate about, as Dr. Simpson mentioned in my bio, uterine fibroids and preeclampsia, a blood pressure disorder in pregnancy that disproportionately impacts Black women and other women of color. And the hope is that the data will also allow the community to study and research other questions or diseases that impact groups that have been historically underrepresented in research. And so I did specifically look at fibroids, and I looked at hypertension in pregnancy. I'm not going to go through the entire process of that, but it was very similar to that of Dr. Chandler. Next slide, please. It was just really exciting to be able to go through the references. And I do, as Dr. Clark mentioned very early on, encourage you to go to the website for the All of Us research portal, which has a public data browser, and will allow you to just kind of play around with it. For me, it was important to think about things that I was passionate about as a obstetrician gynecologist, but also I thought about relating back to other things that impact my family, my community, rare diseases. For example, my father was diagnosed with ALS, which is Lou Gehrig's disease, very rare, really random. And to be able to explore things like that in a more granular way with lots and lots of data from lots of people that typically may not be impacted, but with enough people, you can really study it. So next slide, please. So one thing that we're doing moving forward when I mentioned longitudinal is that there's surveys. And so this slide and the next slide, please, just give you a sense of the surveys that we have so far. But with input over time, we're going to be developing more tailored studies. We've got groups and individual investigators in our region that are developing these questions. One of the things that came out of my demonstration project is that we need more questions that specifically address things related to women's health in a more detailed way. And I know that over time that will happen, and it's just really exciting for the program.
Well, thank you, Dr. Noel. Question for you. So just given, I guess, your surveys and how you're using them, what is the best way for those who engage in the program's behalf to talk about the value of survey completion and retention in order to improve participation in your projects and the research that All of Us does?
The information that's captured in the surveys can broaden the depths of the concepts that can be studied. So as we recruit and retain participants from diverse backgrounds, this will allow us to conduct research in a more representative way. And particularly with those groups that have been traditionally underrepresented in research. These surveys are very important, have been thought about in a lot of detail, and in many ways are trying to fill the gap of other research studies, of other longitudinal research studies. So it'll allow myself and other researchers to really detect changes and trends in disease incidence over time and the factors that may contribute to it. In the chat, we've been talking a lot about nutrition, green vegetables, various types of diets, and you can only get that information if you write in those details and answer the questions. And particular risk factors and other diseases that could be coming into play.
Awesome, thank you. So, I mean, we have seen this evening like the robust process and research and projects that All of Us researchers is overseeing here in New England. How they're integrating social determinants of health, how we're thinking about the studies that they're rolling out, how they're bringing in participants, precision medicine, and how we're trying to target this as much as possible so that we could close a lot of these disparities. But it really takes all of us to be a part of, essentially, no pun intended, but it really takes all of us on this call to really start thinking about how we could play a role in this, either as physician scientists, physicians who see patients, getting our patients enrolled in some of these studies, just educating them on the work that All of Us is doing, and even as community members, how we can either enroll or play a part in some aspects of what we've all talked about this evening. And then to top it all off, it is extremely important to think about how we can continue to engage participants and how we're getting them to complete the surveys and retain them so that we can get the data needed in order to answer the questions that we are seeking to answer. So I wanted to thank all the panelists tonight. I know they have extremely busy schedules, but we all feel that this is an extremely important topic that we need to start and continue to have conversations around if we truly and honestly want to achieve health equity and close the gap in health disparities. There were a couple questions that came up in the chat, and I know there was a lot of top conversation around diet. So if I missed your question, please feel free to pop it back in there, and we'll try to get to as many as we can before the end of this session. But first question I'd like, and anyone can jump in and answer this, but how do we start to really build trust necessary to connect with communities that have historically been disenfranchised, to want to address some of the holistic, be able to connect with them holistically and be able to continue having these conversations where they trust us enough to want to enroll in some of these studies?
In one important aspect of building trust is building a relationship. So that means building a relationship where there's reciprocity, just like we see with clinical trials, when individuals feel like there is something in it for them, as well as in it for the researchers, they're more likely to participate if they see there's some value. So for example, with all of us, as Joel highlighted, when those calls were made to check in on people to see whether they needed resources, some of those people were more likely to complete the all of us surveys. So there has to be a relationship of reciprocity. And then when people are more likely to participate in projects where they see that there's something in it for them too.
And I was going to build on what Paulette is saying there, and it's really about collaboration and co-ownership. I'm going to quote someone else, and I forgot that attribution here, so forgive me, but like, you build it for me, maybe I'll come. But if we build it together, then I'm already there. So it's about making sure that we do all this work together. And I have to say, it's been a learning curve, trying to figure out how to do this. All of us has a group called participant ambassadors who give feedback and who are present to make sure that we make decisions, and we're still learning about that. And there also is an enormous number of organizations that collaborate, including like sororities, fraternities, local organizations even here, the libraries, because we knew that people were gonna, not everybody has the internet and can participate even on a Zoom call like we have tonight. So we would need to have locations where people could go and get the information. So partnership both with the National Library of Medicine, as well as our local libraries like the Boston Public Library, were going to be really important. So a lot of it is just investment, making sure that, you follow the money, we put the money where we would like the activity to be, we value people's opinions, and it's a learning curve. We make mistakes, we are transparent about it, we learn and move forward. So all of that I think is necessary, but it's about partnership, it's about collaboration.
Awesome. And I think that speaks to like how we can start to really engage people at all levels. But then what are some tips on recruitment, especially during pandemic? Like, how are you guys navigating getting people recruited in this virtual landscape, and like what successes have you had, what roadblocks, pitfalls can you share around how you've been able to navigate this during these times?
Is our audience on mute? I can't tell, and if they are in the chat, because I'll be honest, I would love to hear what people think and what their recommendations would be, because to keep everybody safe, we had to stop, right, during COVID, and we did other things like call people, check in on them. But now we're back. We're in a lot of the same places. We are in hospitals, we are in clinics, we are at least at a couple of our hospitals and clinics. People are starting to use vans. I don't know how many of you guys live in Boston. Have you seen like the Brigham and Mass General vans like coming through the community and that sort of thing? So some of that is happening. But so there are ways, and we're also calling people, just working through physicians who are our partners. So there are a lot of strategies to bring people in and to keep in touch with people. But I would love to know what this group would recommend. What should we be doing so that it's beneficial, so that it matters to people, so that people own it and want to come?
Can I speak? Okay. I've been a participant of all of us since 2018. And the difficulty that I have found is that the consistency when someone says they will call you back hasn't been there. And that is something that's really necessary. It was very difficult for me, but I am a nurse of 55 years and I still work. So what I would also like to say, it is wonderful to see all of my children up there of color, because I have always practiced and not had you. So I really appreciate you being here. But that is one thing. And even when I tried to get in for tonight, I've tried to register for 3 days, and change over from Everbright. And I mean that because they make you do so many things for them before they will let you register. And I was just determined that I was going to listen to you all tonight. So, but you're on the right way, and also having the support of your white colleagues who have practiced another way for a long time.
Thank you, Ms. Clark. That really means a lot. And I know all of our participants, that really kind of like warms our heart just to hear you say that, having been working in the medical field space for the time that you have. But it brings up another question for us, like how can we as physicians and physician scientists and physician researchers really bring in our white colleagues and other colleagues in other communities and expose them to this so that they're more knowledgeable and able to either get more people to participate or take the data and the information that's coming out of all of us to treat diverse sectors of patients? Like, what are some strategies we could use to kind of get more of our colleagues on board with with this movement that's happening right now?
If I can speak, I'd appreciate that. I'm a student at The Ohio State University, and honestly, like from my own experience, like as a white man, I came into my education very late in my life. I grew up in a majority white suburban neighborhood, and until I got to OSU, I hadn't really had any idea of, you know, these atrocities being held on these communities, what these communities have gone through, and just that honest education rather than it being like filtered is really was really like transformative for myself, and you know, trying to get involved and not ignoring the damage caused, but trying to actually do the work in order to heal the scars from it. So honestly, honest conversation with your white friends is the best way to go, you know, really delivering on that empathy aspect, because that's what they're not going to help if they don't have empathy. That's the thing. And so trying to teach that, I think, is the most important thing.
Thank you for that. That's really helpful. I mean, and it speaks to the fact that these panels that we're having and what we're doing is going to make a difference and get more people involved and enrolled and want to participate in the work that all of us is doing. There was a question earlier, and this is, I've been trying to keep everything sequential, but there was a question earlier, and then Dr. Clark, you mentioned that all of us is going to start moving into the space of like blood sampling and wearables. And the question was, how are you, or how does all of us plan on managing the shipping of these blood samples and maintaining the quality? Or are there any issues that need to be thought about as far as like how it may impact your studies if you're going to start doing the blood sampling and shipping it into to wherever respective labs.
Yeah, no, thank you so much. And what we did mention is that we're going to get to the point where we'll be able to use that information, but we are up and running. And since 2016, we've been collecting that information, at least, I'm sorry, 2017, during the alpha and beta phases. So we've had several years where we've been doing that information. We partner with Mayo Clinic that hosts all of the samples. They are expert at how you store them. Now the question is just how do we have a process for deciding what studies get done, et cetera, and that we want to do in community. And so there's a process that will need to be put forward for that. And so that is what's in development. So the more conversation we can have, the more input that we can have on how, what kinds of things people would like to see happen, the more we can advocate for what needs to be done. So that's a very, very important question. We have a lot of the material, you know, we have the blood, we have saliva that people have given us, but what should we do with it? That's where we need input. That's where we need you to weigh in.
And are there any more questions? I'm just going to open it up to the audience right now. We have a couple more minutes. I think there was one more. Actually, this is directed to Dr. Dadir. Do you have any thoughts or theories on what changes in medical understanding will result from studying a more representative gene pool?
So from my perspective as a primary care physician and not a geneticist, I think that for reasons that I actually mentioned, there is quite a bit of potential to discover new things. But I would start with confirming things that we already know. I think there are new gene variants that are arising all the time. People are assuming that they apply to all ancestry groups, when in fact we know they may not apply to all ancestry groups. The genetic variant may actually have a different effect, even let's say a protective effect instead of a pathogenic one in one ancestry group, like the LPA gene that I mentioned in cardiovascular disease. I think also, you know, there are some gene variants that just aren't in, apparently, all ancestry groups. So we talked about BRCA1, the ApoL1 gene. You know, it wasn't actually found in ancestry groups of Caucasian or Japanese or Chinese descent, but it was found in West African groups. So I think the research is being done and discoveries are being made, but it's important to involve other groups just for the generalizability.
And one last question. Actually, there's two. So I'll do the first one and then the last one, I'll close out on the second one. For future physicians who are white, how does one navigate the collective racial trauma experienced by non-white communities in the medical field? And due to just the atrocities committed against these communities, especially in research, how do we build up the trust necessary to connect holistically with them? And I think we probably addressed some of that when I asked the prior question, but was there anything else that anyone wanted to add around that? I guess more so, how can our white colleagues really navigate around some of these traumas that have, these historical traumas that communities of color have had to endure over the years?
I'd say read the history, like read for yourself, be able to describe this history to your neighbors and your friends and your families, because I feel like communities of color, we've been talking about this history and talking about why we don't trust the medical field for the longest, yet and folks aren't listening, but we need our allies to be able to speak it for us. And just talking to folks and asking the questions, and it's going to be uncomfortable, but that means that we got to work through that discomfort to develop results. So yeah, that's what I have to say about that.
So I think this is probably the most important question. How can one get involved with All of Us New England? Where do we start? Where do we send everybody to?
And if my colleagues have any other things to add, I'm pretty sure there's a lot of other great ways of having our white allies join this conversation better.
Well, Elizabeth kindly dropped some links into the chat with links on how to visit our website for both All of Us research program, as well as NEMA, New England Medical Association. There's also interest in volunteering, but in fact, we have paid positions as research assistants. You don't have to be a medical professional or really have any medical experience per se to be a research assistant. Follow us on Facebook, Twitter too. I think we're on Instagram.
And
Awesome.
I'm going to say also consider all the different ways that you can work with us, right? So you can do it as a participant. If you actually want to help drive some of the questions that get used, you don't have to have any particular background. Just participate like on Twitter or Facebook and make your suggestions and recommendations. So there are so many ways of getting involved. If you'd like to do presentations, like if you're a part of an organization, I put a thing in the chat, for example, Mattapan Food and Fitness, there are several organizations that do this. And if we want to have other presentations, we could think about doing that. So please stay engaged, please stay involved. That's the only way this is gonna work. Anti-racism, as we all know, takes an active effort. Things will stay the way they are if we do nothing. We all have to get committed, get involved, and do an action if we want things to change.
Awesome. This has been an amazing evening. I am just so glad to be a part of helping organize this and moderate and just kind of have you guys, these amazing physicians and physician researchers, just share their work. I want to thank the audience for coming out this evening. I want to thank all the panelists. I want to make sure that I give a shout out to all of us, just in general, just for being supportive to NEMA over the past few months, being one of our official partners, which has meant a lot to us as an organization. And then I want to just really encourage all of you guys, even if you're not physicians, to follow along with New England Medical Association, keep up with some of the events that we're doing. We'll be hosting other educational sessions. But I think what's most important coming out of this is that the anti-racism work and this equity work just doesn't happen at the policy level, and it doesn't just happen in the hospitals. It happens through research, through science, and it happens in the community. So please follow all of us, New England and New England Medical Association. Stay in touch, and you will be receiving a post-event survey for all attendees, just so we can get your feedback. Again, this is recorded, so you will be able to get access to the recording. Please reach out to, there's two Cheryls here, so Cheryl McLeod or Elizabeth. After this, and they give them time to edit the video, and they will get you a copy of, send you a link so that you can share with your communities and your networks, just really sharing the work that's being done here. And then hopefully we'll see some of you guys at our next sessions, or maybe even as a participant or investigator. So thank you all for coming out this evening, and hope to see you soon.